Welcome to the NWAETC Project Echo. I'm Kent Unruh. I'd like to turn it over to Dr. Brian Wood, the medical director, to introduce our guests.
Well, it's a pleasure to have Dr. Joanne Steckler back with us in Echo again. And you guys may remember Dr. Steckler from a prior talk. She is an assistant professor here and works with the Department of Public Health and is an expert on primary HIV and HIV prevention. Turn it over to her.
Thank you very much. So before I get started, I just want to let you all know that, first Brian asked me to give this talk to tell you a little bit about what's been going on with the recent approval of the first home self-test for HIV. And because I'm going to be talking about a specific test, this is going to have commercial sort of conversation, and I have no money from OraSure, and in fact, they often would prefer if I don't talk about their product. But just FYI, if you're getting CME, I have to give you that disclosure. So you don't really need all of the details. You know, there are a lot of people still living with HIV in the United States, of which the CDC recently estimated that not quite 20%, I think the most recent estimate was 18% of people are unaware of their HIV status. And those close to 20% of people who are unaware of their status are still responsible for over half of the new infections. So identifying people who are HIV infected is one of the priorities for HIV prevention. And the reason for that is once you know that you're HIV infected, you can change your behavior to reduce the risk of transmission to other people. And then, of course, getting someone into care and getting them on treatment has the potential benefits for their lives, as well as the recent evidence that getting people onto therapy reduces the risk of transmission to other people. So there are a lot of ways that people are working on this. Partially depends on the location that you're in, but overall, the general idea is we want to get as many people sort of aware of testing, get testing in as many places as possible. And because some people prefer one testing modality over others, really try to increase the number of tests that we have in our toolbox. And so that's why there's been this interest in home HIV testing. Now, this isn't really new. There's been a product on the market called Home Access that's been FDA approved since 1996. And this data is from it's very old at this point, basically the original approval that from the first year that this was used. And this is a finger stick test where people buy their kit, do a finger stick, do a dry blood spot, send it in, and then have to call for results. So people aren't getting their own results themselves. That in the first year of use, not 100,000 people use this test. Almost everybody called for their results. And the proportion of these folks who are testing positive is actually really quite high, close to 1%, which is pretty remarkable for testing. Now, some of these people were probably known to be positive in either confirming their status or sort of just seeing how the test works, but still 1% is really high. And of the people, of those 175,000 or so who completed a survey, and I'm going to try and talk slower, sorry. Of those 100,000 who had done a test, about half of them completed some behavioral data, completed a survey about behavioral data. And of those folks, not quite 60% had never actually had a test before. So again, reaching a population that had never tested. And of the people who were testing positive, about half who tested positive had never had a prior test. So that's some evidence that even though the number of tests that they sold wasn't going to make a huge public health impact, they were still diagnosing some people who had never previously tested. So this was going to be a tool that, again, wasn't going to replace all other HIV testing, but it just sort of helps round out our tests. The more recent data that was presented from Home Access by the CDC in the conversations at the FDA about the OraSure's home test, this data looks pretty similar. The proportion of folks who are testing using Home Access who are testing positive is still about 1%, but the number of people who are testing positive who have not had a prior test has gone down to about a third. So still, even though we've had testing and sort of promotion testing all across the country, there are still a lot of people who are testing positive who've never previously tested. This is, again, sort of requires someone to actually interact with the company in order to get the results and not get the results themselves. And so there's been interest since 2003 when the first rapid tests were approved and CLIA waived, so very easy to use, just like pregnancy tests. there have been conversations about whether or not there could be home testing, just like pregnancy tests. And the possible benefits, you said, it's all about risk and benefit balances, that more people might get their results, and more people might get their results quicker than if they had to come into the clinic. But there are obviously a lot of concerns that we've had over the years. One, could people do this? Could they get the right answer? There's something that the term is was coined a point of sex testing, so two people deciding to do tests together prior to having sex and what they would do with condoms in that context. There's some concern that if someone tests positive at home, that they're not going to have access to post-test counseling there, that there might be a delay between the time when they test positive and get into care. And if we have home HIV tests but not home STD tests, that we might actually see increases in the amount of syphilis and gonorrhea and other things we're having. So lots of concerns. The FDA had, I think it was 4 conversations beginning in 2003 about what it would take to get a home test to market. And what you can see on this slide is the final kit that was FDA approved last year. And I don't think this is the slide that has the sort of what all these things are. And I actually have a kit that I was going to bring and show you, but I left it up in my office. But it basically it's the same exact device. If any of you are using OraQuick made by OraSure in your clinics, it's the exact same device with basically just some different packaging. There's a stand to put the device so that people don't spill the fluid, and then really complicated instructions that have gone through iterations that people are supposed to read. But otherwise, it looks exactly the same. As many of you know, basically it's read very similar to a pregnancy test. It's basically has 2 lines. This is the control line and the test line. If the control line is positive, but the test line is negative, it's read as not reactive. The control line is positive, the test line is positive, it's read as a reactive test. This obviously needs to be confirmed. And if the control line is negative, regardless of whether the test is positive, this is an invalid result. And I believe the HIV web study site has really much more details about this device if you all want to know how it's done, if you don't have the experience of using it in your clinic. So after multiple sort of initial studies of whether or not people could do it in a supervised setting, could they understand the instructions, this was sort of a many-year process. What I'm showing you on the slide is the results of OraSure's phase 3 study, where they basically tried to make this as similar to real life. So they had people come in for a screening visit. They were recruiting from both low-risk and high-risk sites, and then had people come back for a second visit in order to receive the kit. They did that in order to sort of screen out the people who were less likely to actually use it. Sent people home, told them the test within next week, and then had them come back to get the results of a HIV test that was done as the comparator test at the second visit. So what I'm showing you is basically what was presented at the FDA meeting last May about this phase 3 study. And you can look and see this presentation from OraSure. So they had 5,000 people who ultimately came back for their first 2 visits who got a kit, but there were 100 of those who didn't return or didn't run the test. So they had I don't know why these numbers are different. So I think that I didn't change this. There were more that they originally presented and then took some people out of the study because there was a problem with one of the sites. But then, so it had 5,000 people who were able to do the test, who had a comparator HIV blood test. 59 of them had a problem running the test. And so the performance in this population was based out of 5,500, of which about 2% tested positive. So again, sort of significant numbers of people testing positive in this group. And so what I'm going to show you on the next slide is the numbers that were used for the FDA approval for sensitivity and specificity. And so these numbers are less than, again, the total who are enrolled because there was a problem. And so the number you can see who are testing positive is overall less. There are fewer people who are using the sensitivity analysis. So this was, of the 5,000 people who got the test, there were 96 who tested positive, again, about 2%. And of those, 88 had obtained a self-test result and got a positive result. So 6 96 minus 88 is 8. So 8 people got a negative result when their EIA, and I don't know which EIA that was actually positive. And that gives you a sensitivity of 91.7%, which is the estimate that OraSure has to use when promoting this product. Two things about that number. So in prior FDA meetings, it was set to be that this test would be approved. It had a sensitivity of at least 95%, so it doesn't make that number. And so one of the we'll talk about that in a second. The other is the issue is that you're comparing against an EIA of some sort. Again, I don't know how sensitive that EIA was, and so we're not looking at total infections and window period testing. And again, I'll talk about that in a little bit. Finally, the test was very specific. Of the people who had an EIA and got a self-test result, there were 4,903 people who were truly negative, and only one person got a false positive. So a specificity of really close to 100%. So that looks great, particularly if this test is going to be used in sort of a worried well population with a low prevalence. So we got FDA approved on July 3rd, just about a year ago. Just sort of to sum up, it's a rapid test. It's FDA approved to be performed on oral fluid. So basically the mouth swab, you have to read your results in more than 20 minutes, but less than 40 minutes. They are saying it has a 3-month window period. So time from when you might get infected to when the test turns positive. They are saying it's accurate after 3 months. It's only FDA approved for people to buy it over the age of 17, and that's entirely because that was who was in the study. And it's available currently online and in some pharmacies for close to $40. The company staffs a 24-hour contact line for questions. This is what the back of the box looks like. So there's a lot of information in very, very small print, and for people to read before they decide to purchase it. And one of the things that I find really interesting is this statement here. It says, when should I not use this test? You shouldn't use it if you're going to make decisions about behavior that may put you at increased risk for HIV. So that's their statement, that you shouldn't use this test with a partner. If you both test negative, decide not to use condoms. But that's sort of the only counseling that exists on this box related to window period and this point of sex testing. But there's a lot of information so that people don't spend $40 prior to purchase. But there are a lot of questions. So that got the test to market, but we really don't know what's going to happen now that it's a market. And so we know from home access that some people who have never tested will probably use it. But we don't know whether more people will test. We don't know sort of the larger scale impact of this. We don't know whether or not people who test positive, what that's going to do to linkage to care. That's one of our sort of the big sort of pushes in HIV care, is to work on the cascade. You probably had a lecture about the cascade. So trying to encourage people to get into care as soon as possible and stay in care. There's this issue about sex partners. And then what happens if people decide to stop using condoms when they're actually acutely infected because the test has a long window period? And what will that do to the epidemic? And I'll show you a slide at the very end. Moving from the commercial, I'm sort of going to give you the perspective of the study that we've been doing for the last few years. There are 1 or 2 other studies that are going on around the country about home testing, but we were one of the first to get in, and I'm mostly just using our study as an example, not that it's the only one. And so basically we're looking at high-risk men who have sex with men to see if access to home testing increases the frequency of HIV testing in this group who are supposed to test every 3 months. And we're randomizing people for the comparison to either standard testing or access to getting a single kit. But we're also interested in looking at what happens to their sexual behavior. Will they get more STDs? Will it be acceptable for their use? And so I'm going to show you a little bit of data about that. We'll ultimately have... So we're ultimately going to have 246 people. We have sort of about 190 people. This is surveys from people who are coming off study from 109 people. And the data that I'm showing you has been presented. And if anyone's interested, I can give you the references if they're not in the slide set. But almost all of our guys think that this test has been easy to use. So this slide basically says 96% thought it was very easy, 4% thought it was somewhat easy to use. No one thought it's been difficult. In terms of the question of what will people do with these results. What this slide shows is sort of the likelihood that someone might use these test results with someone might decide to have condomless sex with someone based on having a test at home shown in blue versus what happens if their partner just tells you that they're HIV negative. And this is a high-risk group of guys. These are men who are either having bacterial STDs or having unprotected sex. So it's skewed towards higher risk guys. But what you can see is that of the guys who say they would test negative with a partner, over about 30% thought that they would be very likely not to use condoms with that partner for that sex act. So again, you test together, you both have a negative test, 30% thought they wouldn't use condoms after that, compared to just about 15% who, if your partner says that they're negative, wouldn't use condoms. So people are going to use this test as a way to make decisions, sexual decision making, even though the kid obviously says that you're not supposed to do it. To illustrate a point about sort of partner testing, this is a case report that we published last year about someone who we saw in the STD clinic who reported that he'd had a positive test after testing with someone in our study. So the person who tested positive was not one of our study subjects, but was the partner. And basically, he's telling us the story that 2 months prior to this positive test, 2 months prior, he had sex with one of our study subjects. After having sex with this our study subject said, "Hey, do you want to use this test that we have?" We've discouraged our study subjects from doing this, but they had a positive test. Now, after getting the positive test, what happened? Well, they didn't have sex again, but the person who tested positive didn't immediately get into care, although he did start using condoms with his subsequent partners. So I sort of use this as what can happen. So good, people can get the right results, people can change their behavior, but the person who tested positive didn't get a confirmatory testing immediately. He had somewhat delayed entry to care. And because this didn't happen in a clinical setting, our study subject who had just had unprotected sex with someone who tested positive didn't, as far as we know, get post-exposure prophylaxis, which is what he would have if this had happened in a clinical setting. We've seen some other sort of SIDS that's been reported in the last year. There have been sort of other examples of home testing sort of situations that are sort of out of what we would expect. I heard from a provider that one of his HIV-infected patients who was on meds bought a home test, used it, tested negative, and then decided to go off his HIV medicines because he got that test result. So I think that there are a lot of potential things that can happen. And again, I'm a worrywart, and there are probably a lot of benefits, but again, we don't know how this is all going to play out. My other sort of, if you've heard me talk before, my other interest is about primary HIV infection and window period testing. And what I'm just showing you is a slide to illustrate what can happen if people are testing during the window period. And these are results from the pooled RNA testing program from public health for the first, looks like 8 years of our program. This isn't adapted from one of our publications, but it hasn't really changed. But basically, if these are all men who have sex with men, if they, of the people who are getting screened, it's about 15,000 over these years who had been screened by, we use OraQuick either by oral fluid or finger stick in our population. We have a testing prevalence of about 2%. Again, so these are high-risk guys. If people who are testing by rapid test want to, since 2003, they can agree to get their blood drawn for syphilis screening, but also for additional HIV testing to try and catch them in the window period. And before going to pooled RNA testing that I'm sorry I don't have the time to describe here, but you can find online or I can answer questions. We submit those blood specimens for an antibody test. And over the years, we started off with a first generation EIA that has a very long window period, most recently to a third generation EIA that has a window period of about 3 weeks. And about another 10% of people who tested negative by the rapid test positive for antibodies at the same time as they're testing negative by rapid test. If you look for the people who are antibody negative, about another 10% will be antibody negative but have detectable NAAT is nucleic acid amplification testing, will have detectable RNA. So when we look at sensitivity of these tests in our population, assuming that we've caught everybody, which is probably not true, that the whole program picked up all of these. Antibody testing as a backup identifies about 90% of infections, but rapid testing identified in our high-risk population not even 80% of the infections. So the window period really does have an impact on how well your testing program works. And again, these results aren't relevant to populations that may be lower risk with lower incidence and lower chance of testing in the window period. But if you have a high-risk population, you need to know that the window period can make a difference about sort of identifying true positives and false negatives. Just to sort of illustrate what can happen if more people test with a worse test, this is a figure from a poster that David Katz, the former PhD student, did with us that was presented at CROI last year, and you can find this poster online. But the question is, because people with acute infection are estimated to account for a large proportion of new infections, if you're missing all those people who are testing in the window period, what happens to the epidemic? And what you can see is our base case of testing of HIV prevalence in men of sex with men here in Seattle, we estimate is about 19%, and this is validated in a bunch of surveys. And if you replace our RNA-based testing with home testing with the longer window period, therefore allowing more people to go undiagnosed and basically let this continue in their population, that HIV prevalence will actually increase. This is a total model. This is not reality. This is really just to illustrate that, again, so if in our testing program we're missing a lot of people with our poorly sensitive test, but if you implement a poorly sensitive test in this population and don't change behavior at all to account for the poorly sensitive test, that HIV infections may actually go up instead of down, which is what the whole sort of issue with why the home test was approved. I don't know if there's a minute for questions.
Definitely. Thanks, Joanne.